let's begin our first activity of Brazilian Society of Pediatric Neurosurgery. So it's a great pleasure to me to welcome to Dr. James Johnston here for start our scientific activities in 2022. In 2017, I had the opportunity to do a fellow at UAB, and I met Dr. James. He's a great surgeon, a teacher. I learned a lot in that period, and he became a great friend. Jim is also a sports car race driver, and I invited Jim to speak about treatment of malignant brain tumors and about training. It's very important, very interesting about the training nowadays with new technologies. So I would like to invite Dr. Ricardo Oliveira, our former president of Brazilian Society, and I also like to invite Dr. Francisco Salomão, the former president of ISPM, to comment these lectures after. I hope the discussion could be very interesting. Jim, you can begin. The audience is yours.
All right. Well, thank you very much, Ricardo. I'll share my screen here. Can you all see that?
Yes.
All right. So first of all, thank you very much, Ricardo. It's really a real honor and pleasure to be able to speak to your society today. Like Ricardo said, he spent some time with us in 2017, and I can tell you that he taught us much more than I think we taught him, but we really enjoyed working with him and learning from him and all his experience. During our time, one of his favorite activities, I think, during his visit was that we have a large sports car and motorcycle track and museum, and he went there with us and with me. And like another great Brazilian, I think that he represented his country very well when he was here, and it was a real honor to have him with us. So obrigado, and thank you very much for the opportunity to speak today. So the first thing I wanted to talk about was some work that we've done with using genetically re-engineered herpes virus, G207, for the treatment of recurrent gliomas in children. I don't have any disclosures related to this, but I will tell you that the virus that we used was made by a company called Triavir that provided the virus at no cost for the trial and had no involvement in any of our data analysis or reporting. So oncolytic immunovirotherapy is a very exciting new type of therapy. Well, it's not that new, but it has become a much more exciting type of immunotherapy for many reasons. But one of the reasons why we have had such great success with it here at UAB for the treatment of adult glioma and now pediatric glioma, there are several reasons. One is that the virus is typically inoculated directly into the tumor through a catheter technique, which can overcome issues with the blood-brain barrier, which can prevent other chemotherapies from reaching the presumed target. G207, or viruses can attach and enter tumor cells, replicate within the tumor cells, and directly kill tumor cells, which gives it an oncolytic effect, which can be very useful, overcoming heterogeneity of the tumor in the sense that tumor cells that have various genotype or molecular genetic signature can all be infected by the same virus. And so that gives it a little bit of an advantage over some chemotherapeutic agents. But I think the second thing that's very exciting, second aspect of oncolytic immunovirotherapy, is that when you have that direct killing of tumor cells by the virus, you get sort of a very messy immunogenic type cell death, which results in the lysis of tumor cells, releasing tumor-specific antigens into the cellular microenvironment, allowing for immune activation. And that can overcome the low neoantigen burden you see, especially in pediatric types of tumors. And probably most exciting, it seems to overcome the local immunosuppressive environment that is well described in gliomas, turning cold tumors to hot tumors, meaning tumors that are then visible to the immune system. So we have a lot of experience with the herpes virus G207 here at UAB. Dr. Jim Markert, who's my chairman, has been working with G207 for many years. And this is a very safe virus. It is a herpes virus that is doubly inactivated so that it cannot replicate in normal CNS cells through the deletion of the gamma 34.5 gene, which prevents replication in normal cells, and then doubly safe by also disabling of the viral ribonucleotide reductase by the lack Z insertion in the UL39 gene. The key features of G207, and like I said on the previous slide, is that you get not only direct oncolytic killing of tumor cells, but you're also able to stimulate a robust immune response to the tumor. And that tumor response can occur even in the absence of tumor cell permissivity, meaning even when the tumor cells are actively trying to down-regulate the immune system, this can overcome that effect, which is very important and is becoming increasingly important in our understanding of how glioma and other CNS tumors should be treated. The delayed anti-tumor immune response can occur even weeks and even months after the initial treatment, which I think is a very important aspect of this for long-term control of these tumors. The G207 virus is sensitive to clinically used antivirals like acyclovir that we all use. So if you did have a rare event with a G207 which infected normal cells, you could treat it normally. And probably most exciting as a pediatric neurosurgeon is that preclinical studies have shown that this G207 herpes virus is actually more effective against pediatric high-grade glioma than against adult glioblastoma, up to 11 times more effective in murine xenograft models. So based on all this exciting preclinical data and some of the experience that we've had in adults, we were able to put together a phase 1 trial of herpes virus G207 in children with progressive malignant supratentorial high-grade glioma. As any phase 1 trial is structured, this was going to be the primary objective was to look at the safety of G207 alone or combined with a 5-grade dose of radiation administered about 24 hours after administration of the virus. But we're also going to look at some secondary objectives with some general estimates of efficacy and biological response to G207, looking at MRI changes, performance score of our patients, overall outcome, survival, immune response, cataloged by specific immunohistochemistry analysis of tumor in certain patients where we're able to get tumor after it had been treated, and looking for evidence of G207 shedding. It was a very simple, small phase 1 trial with 12 patients, with 3 patients at each escalating dose level, starting at a 1 × 10⁷ platform in units, which is a very low dose. And then pretty quickly then going to adding 5 gray of radiation in the second 2 cohorts of the study. Eligibility criteria: proven progressive malignant. I'm sorry, I'm going to have to do this. It keeps changing to my key eligibility criteria were that the children had to have pathologically proven progressive malignant tumor greater than 1 centimeter in size. They had to have full recovery from previous treatments, performance score greater than 60, no acute infection or concurrent drug active against herpes virus, and we were not allowed to use transventricular, cerebellar, or brainstem inoculation for any of the tumors. Our treatment protocol was relatively simple. Basically, once a child was identified and included in the trial, they received a preoperative MRI scan, and then using standard stealth frameless navigation system with the Vertec needle, we basically planned safe trajectories and stereotactic placement of 1 to 4 intratumoral catheters. On postoperative day 1, the child went for a high-resolution CT scan to confirm that the catheters were within the tumor and not near a ventricle or a subarachnoid space. And then they immediately began a slow infusion of the G207, a very small amount, 2.4 milliliters over 6 hours. So technically it was not a convection enhanced delivery, but it was a slow administration, allowing for a very slow diffusion of G207 and its vehicle throughout the tumor. And then an hour after infusion, the catheters were moved to the bedside, and the children were followed in the hospital for several days after the procedure with various tests looking for shedding of G207 and looking for other acute side effects. The demographics, age range was about 7 to 18 years of age. 10 of the patients had glioblastoma, 1 had an anaplastic astrocytoma, and 1 had a high-grade glioma not otherwise specified. All were IDH wild type with no favorable genetic signatures. They were all decent-sized tumors with a biperpendicular sum of about 5.5 centimeters in 10 of the tumors. 3 of the patients actually had multifocal disease, and 1 patient had a small amount of leptomeningeal spread, but was treated under the protocol. Of note, many of the patients were heavily pretreated. 8 of the 12 had failed 2 previous therapies, and 4 had actually failed 3 previous therapies. 8 of the patients had 4 catheters, 4 of the patients received 3 catheters, and we were able to put the catheters throughout the supratentorial space, including frontal parietal, temporal, and occipital lobes, in the thalamus, in the corpus callosum, and in the insula. 2 of the patients ended up having asymptomatic tract hemorrhages that were found on the CT scan the following morning. 1 patient actually had a CSF leak from their catheter exit site, which was sewed up at the bedside with no further issues. 2 of the catheters had to be pulled back to an optimal site because they were in several millimeters too long. And 1 catheter could not be used because it was too close to a ventricle. So in that patient, the other 3 catheters were used for administration of the virus. We found that G207 was safe at all dose levels, and all attributable adverse effects were grade 1, and there were no severe adverse effects related to G207. Also of note, we found no evidence of G207 shedding in blood, conjunctiva, or saliva specimens in the patients as they were followed in the immediate short-term hospital stay or at follow-up clinic visits. And 3 of the 4 patients seroconverted to herpes virus at 10 to the 8th plaque-forming units, so at a higher dose level. So looking at secondary outcomes, of course, the study was not powered for secondary outcomes, but just looking at some of our responses, we were very happy to see that 11 of 12 of patients had some sort of a response, whether it was radiographic, neuropathologic, and or clinical. And probably most interesting was that the median overall survival for our cohort was 12.2 months, which is significantly longer than what is seen in the literature for children with recurrent high-grade glioma, which has been universally quoted around 5 to 6 months in length. Probably most exciting is that 4 of the 11 patients have lived greater than 18 months, and actually patient number 12 is stable at almost 2 years since the treatment, again, with a recurrent high-grade glioma. Of note, although the numbers cannot allow us to make definitive conclusions, we found longer survival in patients that seroconverted at the time of the treatment versus those who had baseline antibodies to HSV. This is something we're going to be looking at in our multi-center phase 2 trial, which will be starting hopefully later on this year. Now, also of interest, in 4 patients, we were actually able to get post-treatment tumor specimen. These were children that had been treated and then returned with some sort of progression, whether it was a pseudo progression or a true progression, and underwent either a biopsy or an actual craniotomy for resection of tumor. And of all those patients, what we found was that the tumor was quite different than your expected recurrent high-grade glioma. The tissue was quite liquefied, and we found with immunohistochemistry markedly increased CD4 and CD8 tumor infiltrating lymphocytes, even distant to the original catheter placement. There was no evidence of HSV1 staining, which suggests that there was not ongoing replication, but what we were seeing was sort of a longer-term immune response to the tumor itself. And probably also of very significance, we found increased expression of checkpoint proteins PD1 and CTLA4, which suggests that checkpoint inhibition drugs like Pembro and Imipulab may be quite useful for next generation studies of this kind of immunovirotherapy. The radiographic response we saw in most of the patients was this polycystic degradation. This is a good example of, you can see over time, the formation of these small vacuoles as the tumor responded to the initial oncolytic effect, and then further, we think, with the influx of immune cells. In the four patients that were able to get post-treatment tumor specimens, we saw a significant increase in CD8 T cells that were presumably specific to the tumor, as we did not find HSV in these specimens. And this kind of goes with what I was talking about earlier, is that this was a shift from cold tumors to hot tumors, meaning tumors that there was some recognition by the immune system with some control of tumor growth by the immune system after the initial viral treatment. Like I said before, we found no evidence of HSV1 staining in these tumor specimens after treatment. And we also found CD8 T cells distant from the initial catheter placement, which again suggests that we were getting a more, at least regional effect with tumor infiltration by tumor infiltrating lymphocytes well after the initial treatment. And also of a lot of excitement to us is increased expression of checkpoint proteins like PD-1, PD-L1, and IDO after the G207 treatment, suggesting that these tumors may be quite amenable to checkpoint inhibitor therapy as a adjuvant to the G207 therapy. So the conclusions we brought from our very small study, but quite exciting, was that first of all, the primary objective was met, which is that G207 administered by catheter seems to be safe and tolerable at their maximum planned dose of 10 to the 8th. And there were no significant surgical complications, meaning that the technique was not that hard to do, which I think was a little bit of a surprise to me. I was concerned about having some risk of hemorrhage and whatnot with placement of the catheters, but they seem to be quite well tolerated. And then secondary objectives, although the study was not powered for these, were quite exciting as well, looking at some sense of efficacy, meaning significant improvement in the overall survival of our small cohort, and some evidence both on imaging as well as on immunohistochemistry afterwards that there was infiltration of tumor infiltrating lymphocytes, CD8 and CD4 cells, suggesting that the tumors were now hot and potentially amenable to other immunotherapies. And like I said, patients who seroconvert may have improved outcomes, and we saw no evidence of virus shedding. So right now we're are underway in our phase 1 trial of G207, looking at recurrent pediatric malignant cerebellar tumors. We've really just started this past year. The preclinical data in medulloblastoma is actually even better than high-grade glioma, suggesting that it is quite sensitive to this kind of immunovirotherapy. Eligibility criteria has been similar to the high-grade glioma patients, with the exception that these children, we have the option that if they come and the tumor is too big, we can actually do a debulking surgery where we remove almost all of the tumor and then leave catheters behind to allow for administration of the G207, and then with the option to come a month later to come and remove any tumor that is left at that point. So thus far, we've had 3 patients that have been treated with medulloblastoma. Our first patient is now about 16 months post-treatment and stable in terms of imaging, as well as obviously still alive and doing well. Our other 2 patients actually presented with more aggressive disease, with metastatic disease, and did not do nearly as well. But of note, our most recent patient in their post-treatment tumor that we were able to obtain did show significant infiltration of CD8, CD4 cells, as well as some suggestion of upregulation of other immune interferons and whatnot, suggestive of an active immune response to the tumor. So I think that we're very early on in all of these days, but we're very encouraged by these early results. So of course, this is a very large type study, and I'm just the neurosurgeon putting the catheters in and working along with my colleagues in oncology and molecular oncology, Greg Friedman, Jim Markert, and Josh Bernstog have played an incredibly important role in all of this. And Jeff Leonard, who's one of my colleagues at Nationwide Children's in Columbus, was also invaluable for conducting of the trial. So anyway, I just wanted to thank you, obrigado, for your attention on this, and I'm happy to answer any questions you might have about the trial and what our next steps might be.
Gene, I think we can move to another lecture and do the discussion all together. I think
okay, sounds good. Sounds good. All right, hold on just one second. Oh yeah, here we go. Hold on here. Screen share. There we go. All right. Can you see this? Can you see my screen now?
Yes.
Let's see here. Is it getting big there?
Okay.
Can you see that all right?
Yeah.
All right, good. Sorry. Okay. So the next thing is I think like Ricardo said earlier, this is something that I think is it's very I'm very interested in this, and I'm actually quite interested in your thoughts on this as well. So please, if you have questions along the way or at the end, I'd love to hear what you think about this. So anyway, I wanted to present sort of a vision that I have, and not just me, but others have, about sort of the change and evolution of global surgery training. You know, obviously, we're all going through a very rapid change in the way we do things. I mean, this is a perfect example with things like, you know, Zoom-based conferences and webinars. But I think that there's really a lot of other things that are going on that I think are going to be really important to improve our ability to train each other and to really have these exchange of ideas that to this point, I think has been somewhat limited by time and space, I guess is the way I'd put it. So anyway, I know that you guys all know this stuff, but you know, since 2015, global surgery has finally arrived on the global health agenda as an important component of global health. And I think that you know, we as neurosurgeons have a very important role to play in all this, you know, not only in the training within our own countries of our, you know, people who are interested in pediatric neurosurgery and neurosurgery in general, but also in regions that are not as well served by the level of expertise and knowledge that we have as, you know, neurosurgeons from well-developed neurosurgical health systems. As a pediatric neurosurgeon, you guys all know this, that, you know, pediatric neurosurgical workforce is quite low when you look at various parts of the world. It's higher, obviously, in North America and Europe. Brazil is very well represented in terms of neurosurgical expertise. But there are parts of sub-Saharan Africa and Southeast Asia where the numbers of pediatric neurosurgeons are significantly lower than what would be needed to take care of what's out there to take care of. And so the big question is, how do you scale that up? How do you increase neurosurgical capacity? And that's obviously a very complicated problem. So one way that people do it, and I'll just give an example of what we do here at Children's, and we have what's called a global surgery program, where we set up a program to establish durable collaborative relationships with some major children's hospitals in Vietnam, Kenya, and Ghana. We have a 3-activity model, meaning that we have teams of surgeons from Children's of Alabama who will go to work with our colleagues at these children's hospitals to do teaching, in the OR training, lectures, etc. We have had a visiting fellows program for about 6 years now. Ricardo was one of the fellows that we hosted during that time, and we've had fellows from a number of countries. where fellows can come, spend some time with us, see if there's things that are interesting or that they can take back to where they work that might be useful or improve their practice based on their needs. And then I think the third thing is a little bit more novel, and I think is becoming much more of an accepted thing, is the use of virtual presence and augmented reality mentoring to continue collaboration after you've had these visits. We've been fortunate to work with some children's hospitals in Vietnam, like I mentioned, that have been it's been a really great partnership in terms of building programs. We've learned a lot from them based on how they do their pediatric neurosurgery and adult neurosurgery. And then they've been able to work with us and borrow some of the things that we do that have helped them to build and improve the quality of their neurosurgical programs. We have a craniofacial program that we've been working with Komfo Anoche Teaching Hospital in Kumasi, Ghana, again, for about 5 years now. This has been spearheaded by one of our craniofacial surgeons, but it's been quite impactful in terms of helping them set up a true craniofacial program with maxillofacial surgery and neurosurgery, where they're doing basic craniofacial surgery, trauma craniofacial surgery, cleft palate work, and other things that previously were not being done. And it's been a very good example of sort of this way you can build sustainable relationships through training to improve a surgical program. Dr. Brandon Rock, who is a good friend of Ricardo, has been working with one of the children's hospitals in Hanoi. He works with Dr. Nguyen Duc Vien, he's there on the right, who's a very talented neurosurgeon in Vietnam, who has helped to build a very strong pediatric epilepsy training program and a pediatric epilepsy program based on, again, that 3-step model we were talking about with shared visits with our team going to work there in Hanoi, Dr. Lien sending some of his team, his senior residents and junior attendings, nurses, epileptologists, pathologists, EEG technicians, et cetera, to Birmingham, and then bringing back some of that expertise to set up a very successful epilepsy program, which has become really a model for one of the ways that you can do this sort of work. We've also been working with Dr. Dong Do Tan Khan, who is on the upper right-hand side there, who is the head of pediatric neurosurgery at Children's Hospital Number 2 in Ho Chi Minh City, working with them for about 7 years now on development of their pediatric tumor, craniofacial, vascular, and hydrocephalus programs. And those have been really very rewarding in terms of some of the not only clinical training that's come out of this, experience sharing, working with them, and them working with us, and then also research collaborations, which have resulted in some early papers, establishment of some databases, and then also collaboration that they are now working with other pediatric neurosurgeons in their region, as well as part of the larger spina bifida and hydrocephalus global network. So again, we at Birmingham have had our experience with this, with meeting and working with our collaborations. But a lot of people that I meet ask me, well, how do you set up a program, and what are the barriers to that? And so we did a survey back in 2017 looking at this question, and we found this is among the this is of the membership of the pediatric section of the AANS and CNS, so basically North American pediatric neurosurgeons. And we found that, first of all, that a lot of people actually did a lot of global neurosurgery, but they seem to do it with a lot of different organizations and not in a coherent, structured manner. And when we talked to them, we asked them what were the main barriers they had to doing or finding these collaborations. And they basically said that, first of all, was that how do it's hard to do it because, first of all, you have your own practice and call. You can't leave your practice and, go spend 6 months at a time or even a month of your time working with a collaborator. And the other big one that we found was that it's hard to find partners. It's hard, we were able to work with our various partners basically through friends we'd met of friends at meetings, and you guys know how that all works. And so what we came from this is we said we had to find a better way to connect people so that they could find collaborators and then build these type of longstanding collaborations and sort of contribute to the sharing of knowledge and neurosurgical expertise. So I love this slide. This is from a friend of mine who has a company here in town that does some really interesting software development. He's a cardiologist, and he always makes the point that, you know, medicine seems to be really far behind the rest of the world in terms of, you know, you look at business and, you know, you can go on your phone and order a Snickers bar from Amazon, and a drone will fly it to you. Whereas in the hospital, you know, we're still sending mail to each other and using faxes, beepers, and, you know, as surgeons especially, we're innovative, but at the same time we're also quite conservative about how we do things. And so when I think about this, I think that, you know, surgery is one of those things that it's really an apprenticeship. You know, you know this as well as I do, that, you know, it takes time to learn how to do what we do. And the model that has sort of emerged as the most effective model for teaching is the Halsted model, which is, you know, William Halsted, of course, was a general surgeon. He was at Johns Hopkins, who first instituted the whole concept of residency training and having surgeons live in the hospital and spend years of time essentially following around and working with senior neurosurgeons to learn something. So Harvey Cushing down here in the left-hand side here, you see this is a great example. You know, he would operate, he was an incredible neurosurgeon, and people would watch him and learn. And over time, they would learn his techniques and ways to avoid complications, and they would become neurosurgeons. And so our model for a Halsted model is obviously lectures, like what I'm giving you right now, residency training, so spending a lot of time in the hospital. And then once you're done training, you have mentorship. So you still have ongoing relationships with either the people who trained you or other people you've met at meetings or other things to ask them questions about cases or to continue to improve as a neurosurgeon. So what I guess I'm thinking about is, well, this Halsted model has served us quite well for a long time, but there's a lot of new technology out there that I think we can add to this to improve on that model, to act, not to replace it, but to complement it as we move forward. And so the way I think about it, there's really three aspects to that technology. One is social network connectivity, meaning we have to find each other. We have to be able to find mentors with mentees, teachers with learners. And right now that's kind of hard to do. You know, we're all in our own neurosurgical societies. We're all with our different languages. You know, we have different meetings we go to. Some meetings we go to, sometimes we don't. And so it's not an easy way to find each other. The second is you have to have software where two people can share a reality. They can both be seeing the same thing at the same time so they can talk about it. And the third thing is you have to have some sort of hardware that's easily wearable for surgeons, meaning that doesn't interfere with all the other stuff we wear, like our loupes or our microscopes or other things we do or we need to use for our daily life. So the other way to think about this is the big picture from a 30,000-foot view is we have lots and lots of mentors, people who know how to do surgery, neurosurgery, and we have learners who are fewer, but we're trying to make more of these people over here, okay? And right now, of course, the way we do it is it's a little bit expensive and slow, meaning that, you know, people who know how to do it, they have to fly over, they have to spend money, they have to spend time to try to convey their experience to the learners. And then sometimes the learners also can fly over here. But of course, there's money that goes with that and time and things that sort of limit the amount of exchange you can have between these two, you know, two groups of people. So what we really need to do is kind of have something where we're just instantaneously connecting each other with each other so that we don't have to rely on American Airlines or you know, the Hilton or other things where we spend most of our money and resources right now when we try to do these kinds of exchanges. And probably more importantly, we should have it so it's really easy. We can connect with multiple people at the same time, and learners can connect with each other much more easily so that they can become mentors and start teaching people around them. So not having to rely on, you know, the standard, you know, developed neurosurgery system with a less developed neurosurgery system. So many of you probably know or knew Mr. William Harkness. He was a great friend of mine and a legend in pediatric neurosurgery. He passed away, unfortunately, this past year. But you know, one of his things that he did the last few years, and I've been privileged to work with him on it, was development of InterSurgeon. And some of you may know about it. But basically, what William's real vision of this was that global surgery, not just global neurosurgery, but global surgery is a social network. You have lots of different players, not just surgeons, but you have nurses and anesthesiologists and hospitals and governments and equipment providers and nonprofit organizations and et cetera, who are all trying to do the same thing, but they don't really talk to each other or know what each other are doing. So why not create something that's sort of independent?
Abril, então?
Sorry? Oh, sorry about that. Could you guys hear me okay?
Yeah, you can
Okay,
go.
sorry, Dr. James.
No, it's okay. It's okay. I want to make sure my internet didn't go out or something. So, so we created this InterSurgeon basically like on the same kind of architecture like Facebook or Airbnb or Yelp or Uber or Tinder or something like that, where you have a decentralized social network architecture where people can join and find each other through creating profiles and making offers and requests, and then building in algorithms that will connect people with each other for clinical assistance, education, equipment exchanges, training exchanges, and research collaborations. So for those of you who don't know about it, I urge you at some point to just come take a look. It's intersurgeon.org. And what's happened over the last 2 years is just sort of a real rapid growth of our membership, where we now have over 800 members in 107 countries. Most of those people are actually neurosurgeons, although we are starting to grow in non-neurosurgical, all the other surgical subspecialties, the anesthesia and obstetrics. The principles of InterSurgeon that is that it's free, it's independent of any particular organization. There's no advertising. Members go on there to create a profile based on basically, who you are, where you're from, what sort of surgery you do, what's your expertise, or what do you want to learn, what kind of equipment do you have, what kind of equipment do you need, what healthcare, what hospital are you at, how can you get in touch with each other, et cetera. And then we have a matching algorithm that then automatically connects people based on these different qualities of their profile. In addition, members can search on a map, and you can browse and click on people's icons and then communicate with them. And then all members actually get free Help Lightning augmented reality software. This is a really neat, I'm going to talk about it in a second, augmented reality software that allows you to do virtual mentoring instantaneously through your smartphone or through an iPad, which we found to be quite useful. We have subspecialty champions in a lot of different fields, not just neurosurgery. Right now, most of our subspecialty champions are American or British, but we're very interested in getting champions in essentially all countries and all regions of the world. But right now, that's kind of where we're at. If you're interested in becoming involved with that, you can email me at the end, and I'd love to get you involved and send you all the information you need to show your friends about this. We have a lot of partnerships with G4 Alliance, which is a consortium of about 80 nonprofits and academic departments around the world, working towards surgical, obstetric, trauma, and anesthesia care capacity building. We have a relationship with the United Nations Institute for Training and Research, as well as relationships with many of the major North American neurosurgery societies. So like I said before, I think that our global surgery training model is changing, and I think that we all understand that having these long-term collaborations between mentors and learners is very important for true capacity building, sustainability, and development of neurosurgery expertise. Visiting fellowships, I think, are very important. It's very difficult to replace the ability to interact with people personally. Webinars, Zoom conferences, boot camps, WhatsApp, et cetera, are all very important. And I'm sure you all use that as we do. And I would submit that the next thing to consider is this augmented reality mentoring, which has become quite easy and quite common in the non-medical world. We actually experimented with this a while ago and set this up in 2016 with our partners in Vietnam, basically setting up this Help Lightning type software with for neuroendoscopy, and found it to be quite useful for mentoring for ETV. The way it works is quite easy, where you can set it up to observe an endoscopy tower of any sort, and then that image is then transmitted to the learner. This is the learner's endoscopy tower, and then that image is then transmitted to the mentor. In this case, the mentor is me. I'm sitting here in Alabama. These guys are in Vietnam, and basically I can see what they're working on. And then probably more importantly is I can talk to them while they're working on it, and I can interact with their field. I can put my hand into their field. I can draw on their iPad to mark things, etc. And we found it to be quite useful for neuroendoscopy training. So that pen you see here is actually Dr. Rock sitting in Birmingham, and he's telestrating on our iPad in Vietnam, walking us through where we would do our opening for an ETV. And sort of talking to us as we're going through the procedure, letting us know that the procedure is done, that it's time to stop. Can you guys see that pen that's sort of in that screen there? All right, so we found that to be quite useful for neuroendoscopy. And actually we did a study on it, which with our partners in Vietnam, where we showed that it was quite safe to use, and actually was able, previously they were not doing ETV due to some complication issues. And after we worked with them for about 25 cases, their results became quite similar to ours in Birmingham. And really it was just that little bit of mentorship that we all need, where you have a more senior neurosurgeon who can look over your shoulder and say, I would stop at that point, or, there's some scarring that you see there, or, I would just put in a shunt, those kind of things. So again, our colleagues in Vietnam knew how to do ETV, or they had done some training in ETV, had an endoscope, had some familiarity with doing ETV, but they never had that last bit of mentorship for more complicated ETVs, which this sort of augmented reality allowed for us to kind of give them that ongoing mentoring after we had left and after they were not here in Birmingham. So the next version of this we found has been to do a hands-free version of this, meaning how do you connect this kind of augmented reality software to smart glasses? And so Dr. Khan wanted to improve his craniofacial skills. He had done some craniofacial surgery. We had done some work with him there with visits. He had spent some time with us doing some craniofacial surgery, but we wanted to kind of allow him to kind of improve on that skill set. So there's a newer version of this that we've been using, where basically we use smart glasses, where these smart glasses, they're by a company called Vuzix. They're relatively inexpensive. They're about $1,500, which is cheaper than a flight, for example, for me to fly to Vietnam, but about $1,500. And this is a collaboration between InterSurgeon and Ohana One, which is a nonprofit that's in Los Angeles that's dedicated to technology-based surgical mentoring. And what we did was we combined that Help Lightning augmented reality software with the smart glasses. And we just finished a trial with our collaborators in Vietnam, in Hanoi, and in Ho Chi Minh City to see how useful it might be. And so the way this works is actually quite simple. We mailed these glasses to our collaborator, Dr. Khan, in Ho Chi Minh City, with the software already loaded into the system. And he can call me by looking at a QR code. It will call me. This is me. This is it's 12 hours difference from Vietnam. So I'm always quite tired because it's about 10 o'clock at night, which I'm getting older, so I get a little more tired then. But he will call me, we'll talk a little bit about the case. And then what he can see out of his smart glasses is then transmitted to my iPad. And this is my iPad that I'm looking at here in Birmingham. This is a video that kind of allows you to see a little bit of what we do. We typically will allow Dr. Khan and his team will do an exposure of the cranium. And then we're able to telestrate onto a frozen image where we can draw, well, this is where we might make our cuts for our expansion for this child has a multi-suture synostosis and is older, so it's a little bit more complicated in terms of how we're going to go about fixing them. Of note, we can have multiple people on the call. So in this case, this is actually my colleague in craniofacial surgery, John Grant, who's on it with me. So there's the three of us on the call. And then we can kind of watch him operating. This is him operating. Then we can freeze it again and then draw the next step of what the cuts might be and why we would do it, etc. The way I tell people, it's sort of like there's a saying that says, a picture is worth 1,000 words. A video is worth 10,000, but a video where you can interact and telestrate and give feedback is worth 100,000. It's really quite helpful for that last little bit of training, I think, for increasing surgical skills. In addition, I find it to be quite social. It's very easy to collaborate this way. It's easy to call each other, just like we call each other on our phones with our WhatsApp. We can call each other with Help Lightning and kind of keep our relationship going. We can also wear the glasses in clinic, looking at films, looking at patients, etc. So we did about 6 cases over several months with Dr. Khan. His surgical volume was significantly decreased due to COVID in Vietnam, but we found it to be quite useful in terms of improving his comfort level and understanding of more complicated craniofacial techniques for some of his more complicated craniofacial patients. So currently we have 5 different neurosurgery teams that are all using this software as part of this trial that we're conducting with Ohana 1. Of note, there are actually 50 teams of surgeons using the glasses and the Help Lightning software as part of a much larger trial that's going on involving multiple surgical subspecialties. The main collaborations have been between UAB and our partner hospitals in Hanoi and Ho Chi Minh City, but also partnerships between Weill Cornell in New York City and Tanzania, Detroit, Michigan, Henry Ford, and Myanmar. And then within Kenya, Moody Qureshi, who is a neurosurgeon at the Aga Khan in Nairobi, is using them to mentor some of his junior surgeons in a regionally outlying hospital outside of Nairobi. So again, I think there's been this evolution in global surgical training, which I think everyone is starting to understand and work with. Clearly, there are more partnerships between developing neurosurgical systems as learner surgeons become mentor surgeons. Digital collaboration is obviously a very important tool that we're all using already. And I think this emphasis on education and long-term partnerships is important and can be reinforced by using virtual mentoring as a nice addition to what we're already using with our smartphones and WhatsApp and webinars and things like this. So I think the next question really is a big question, which is how to scale up this technology in such a way that more people can use it and find out what it's useful for in their collaborations. And I think that's where the exciting things are going to come from all of this. So anyway, thank you very much. Again, if you're not a member of InterSurgeon, please join. It's free. Tell your friends about it. If you point your camera at that QR code, it'll take you there directly, and it's quite easy to do. And in addition to making your profile, it's important to make an offer or a request so that people can find you, and the algorithm will basically create potential matches for you that you can then find out about and start the conversation going with potential collaborators. So thank you very much for your time, and I'll stop my share there. All right.
Thank you, Jim. It's amazing, amazing. The two lectures are so amazing. Thank you so much.
Ricardo, I can't hear you.
Can you hear me? Can you hear me now?
Oh, there you are. Sorry. Can you? Yeah. Sorry about that. Sorry, Ricardo. What'd you say?
It's amazing. It's amazing lectures. Very interesting. And I would like to invite Dr. Salomão and Dr. Ricardo Oliveira to comment and to moderate the discussion.
Hello. Amazing. Two lectures are very, very interesting. And I think, Ricardo, that we are among friends, so we can open our discussion with all the members. I have some points. The first is it's very interesting how the virus emerged as a potential anti-tumor therapy. It's very nice to see this. We have a curiosity in Brazil. Maybe Juca could be talk about a little bit more, but we had in Brazil in 2016, I guess, Zika virus epidemic, mainly in Northeast region. And some papers recently showed a relation, potential utilization of the Zika virus in glioblastoma as a tool improving the prognosis in patients with glioblastoma. So of course it is a research paper, but it's a curiosity. So in South America, even in Brazil, we had a epidemic with this virus. And one question it's a curiosity for you: how safe is to work with a virus in neurosurgery?
Well, so yes, that's a great question. I mean, I think that G207 is very safe. I mean, it has the doubly the gamma 34.5 is knocked out, so it cannot replicate in normal cells. And then we have a double safety mechanism with the LAC-Z insertion as well. So that's a great question. We've not had any reports of any viral replication or herpes encephalitis in any of the adult patients that have been treated, and that is a large number actually now. I think at least 100 over the years, and again, we had none in our children. So I think that the risk of that is low, but I think that's a very good point. That's one of the reasons why we do these phase 1 trials, and I think a phase 2 trial with many more patients will be very important to get to confirm that. But in all the animal models and in the human models, we think it's very safe.
Okay. Salomão, you have some question?
Yes, I'd like to comment something about the second speech, but if you want to go on discussing the first one, I can wait. No problem for me. I'll be here till the end.
Okay.
But firstly, I would like to congratulate Jim for the two wonderful pictures with the clarity with which he dealt with all the circumstances regarding both conferences, and since it was commented, I would like to thank him for the mention to my very good friend William Harkness. That was a fantastic soul devoted to the subject of global surgery. and that I, as president of ISPN, had the honor to support in this.
Well, thank you very much for your support, and I know that it was the ISPN support at the very beginning was the most important to get the ball rolling. So thank you very much.
Thank you.
Jim, what about the ethical and the legal considerations about this mentorship? So, of course, if the case is going well, everybody's happy, but
Yeah.
do you have any concern about the ethical and the legal problems because of this mentorship?
Absolutely. I think that's a very important point. We actually have we address that on our site. We actually have, when you become a member, there's a series of guidelines and things that people have to agree to before, getting involved in this. What we tell people is that this is not, especially the augmented, the glasses or that stuff. This is not something you do at the very beginning of a relationship and you don't know the partners. This is not something that is a replacement for your standard collaborations that people do. This is an adjunct. This is something you would do with a partnership that you're very, very comfortable with and you understand each other's expertise and limitations, et cetera. For example, those cases we do with our collaborators in Vietnam, we've been working with them for a long time. We know the quality of the surgery that they do, and we are very clear and careful to not do anything that we don't think is a reasonable small improvement in what they're doing already. And I think that's a very good point. Now, that said, I think it still is important, though, to not let that concern keep people from even working on it at all. I think because that's the most common criticism that we get when we talk about this, and we totally agree with you on that. But the way we put it is that people are already doing doing surgery, myself included, where sometimes we don't know, we've not done that particular procedure before, or we're doing a variation of it that's more severe than we've done in the past. And I think the ability to collaborate with somebody who has done a lot of those things or has that expertise is better than to not call them at all. And so I think it's definitely a fine line. I think you have to only do these things as part of a much larger relationship and collaboration. But I do think it's going to be important going down the road.
Ricardo, we have two questions, and I invite Jukai and Patricia to talk themselves their question. It's a pleasure for us.
Good evening again. Thank you very much, Professor Johnston, for both your talks. I would have curiosity, can you see any difference in the quality of training and in the quality of care offered to patients according to the country recognizing pediatric neurosurgery as a subspecialty apart from general neurosurgery?
Well, I mean, in my experience, I think that, just working with a few countries, obviously I can't comment on everywhere. I think that those countries where pediatric neurosurgery is encouraged and recognized as a separate specialty, that it definitely is better because of, as you guys know, there are so many specifics about what we do and the mentorship that we're able to get by working within our smaller field with more experienced neurosurgeons who've been doing pediatric neurosurgery is a very important thing. And I think that's one of the reasons why these kind of collaborations are so important. For example, in Vietnam, pediatric neurosurgery is not really recognized as a separate specialty, and neurosurgeons don't tend to do pediatric neurosurgery fellowship historically. But that's changing, and that's the partners that we're working with. That's what they're doing. They are building these fellowships and training experiences for their trainees, and the quality of the training that their trainees is getting is so much better than it was for example, the neurosurgeons that we originally started working with who had not done pediatric neurosurgery. I think it's I agree with absolutely with you. So, And if you look historically, I know in the United States and Canada, with the advent of pediatric neurosurgery as a subspecialty, that's when so much improvement was seen in the quality that we do. So have you found that in Brazil, or what is your experience in Brazil?
Here we are evolving in this area. We have a very strong society, some decades aged already. I'm looking to three presidents of the society, Professor Salomão, Ricardo Oliveira, Ricardo Gap. We are always in contact with each other, but in the other way, it's not recognized by the Federal Medicine Bureau as a separated subspecialty. So I think it will come in years to come, but it's not already established.
Yeah, it's interesting because in Brazil, we have only pediatric surgery recognized as a subspecialty. For instance, we don't have in pediatric neurosurgery or in cardiology or urology or any other. Only in pediatric surgery. Only pediatric surgery is recognized. So it's something that is in Brazil, as Juca said, we have a very strong society, but we don't have, we can't use this term subspecialty in pediatric neurosurgery. Patricia, please.
You have a question, Patricia? Want to ask?
I'm here.
Yeah.
Hello, good night to everyone. Thank you, Dr. James, for your presentations. And I'm very interested about the immunotherapy with virus. And sorry, but I don't understand very well. What are your criteria to choosing a virus to use in the immunotherapy?
That's a great question. You know, there are several viruses that have emerged. You know, polio virus, adenovirus is another, herpes virus. Those are the three main viruses, although there are others that have been used. A lot of it has to do with the ability to replicate in tumor cells, which a lot of that has to do with, you know, looking at specifics of replication in tumor cells but not within normal brains, you know, normal neurons. And so the ability to selectively knock out or replace those genes to make them safe is obviously a very important component of that. A lot of it is also institutional, meaning, you know, if a specific research lab or institution started with poliovirus in 2012, a lot of times they're still working on poliovirus, but they have different genetic modifications to it. Or for example, at UAB, we have traditionally been a herpes virus institution. So we have HSV G207, which is the one I talked about, but we also have others, MO32, which is another one which has IL-12 that's inserted into the genome of the virus, which allows for creation of IL-12 in addition to the infection, because that's thought to increase the immune response to the tumor. There's other ones with other either interferons or other immunomodulators that are put in that can go. So again, I think that a lot of it's historical, and then a lot of it is just based on what's safe and what can be manipulated genetically.
Okay, thank you.
It's very expensive. Do you think this therapy could be included in a current therapy for brain tumors, or do you think that it's still experimental for a long time because it's very expensive?
Well, it's definitely experimental, although, like I said, we'll be starting a phase 2 trial later this year that'll be multiple North American centers. which will allow us to go a lot faster. So hopefully we'll be able to get, 50 or even 100 patients within 2 or 3 years. And the FDA can approve some of these medications before a phase 3 trial. And at that point, it would be much more available. Cost, it's hard for me to tell you how much it'll be. It probably will be expensive at first, for sure. Just because there's not that many patients that are going to be using it. And there's only 1 or 2 manufacturers that will be doing it. And so that's normally what happens is they charge a lot at first.
Dr. James.
Yes.
Thank you. Thank you for your great lecture. I think I have, my question is almost the same as Patricia, because you use immunotherapy, for example, for a high-grade glioma.
Mm-hmm.
We know that glioblastoma, they do a immunosuppression. So
Mm-hmm.
that's why they can be a target with this modification with GO7.
Yes.
But how about low-grade glioma? Because in pediatric neurosurgery, this is our problem in brainstem tumors.
Yes.
Do you think we have space for this immunotherapy for low-grade gliomas?
Yeah, so that's a great question. And we talk about that every day, because I think you're right. I think that use of these sort of immunotherapies for low-grade tumors might actually be better, even better than for high-grade tumors, because the low-grade tumors grow more slowly and can probably be better controlled by the immune system than a rapidly growing high-grade glioma. That's one of those things that we would like to do once we, like I said, we've proven safety in our phase 1 trial. The phase 2 trial will prove more safety and allow us to get more FDA approval for expansion to non-high-grade glioma, and that is our next step for sure. I think that's a great question, and theoretically, we think that it would work better than against high-grade glioma, but again, it's hard to know.
Thank you.
Jim, as you know, the neurosurgical knowledge increases so fast. So
Mm-hmm.
all the societies is very worried about the training for young neurosurgeons, for people, residents and fellows.
Mm-hmm.
But do you think this technology could be interesting to retraining or refreshing seniors neurosurgeons? Do you think this partnership could be interesting for in different ages of neurosurgeons?
Absolutely. I think that's a great thought. And like I said, that talk showing this was for global neurosurgery with doing things. But I think that this kind of technology could be very useful for neurosurgeons in general, or surgeons in general. I mean, I don't know about you, but I don't get coaching. Like if I was a soccer player or a tennis player or a violinist, I would get coaching, right? Even though let's say I was very good at it, I would still get coaching, because you can always keep learning, you can always improve your technique. But neurosurgery and surgery in general, once you finish your training, a lot of times you're just operating by yourself in an operating room, and that's how good you are. And so I think this kind of technology could be really great for continuing education, assessment, allowing for, like you said, older neurosurgeons to learn new techniques, younger neurosurgeons to learn from more experienced neurosurgeons and existing techniques. I just think as it takes away the whole travel, taking time out of your practice, being able to just go into your office and open your iPad and watch a 1-hour session with a young neurosurgeon who's doing a craniopharyngioma or a complicated spine case or whatever, and being able to watch them and talk to them a little bit as they're doing it, I think that would be invaluable for overall improvement of neurosurgical skill in our community. So yeah, I think that's a great point.
Okay, we have one more question. Charles, could you ask for the question, or?
Yes, I can ask. Yeah, good evening, everyone. Dr. Johnston, thank you very much for the 2 very nice talks. I'd like to ask you, how do you intend to take advantage of the fact that those patients with when seroconverted did better than those with the immunoglobulin, like for long-term HSV? Do you intend to expose the patients like systemically to some sort of virus combination, or what's the plan?
Well, so first of all, we don't know if that's a real finding or not, because it's just such a small number of patients. But if it does turn out to be a true finding in our larger study, what that suggests is actually that children or patients who've not already been exposed to herpes virus will have a better response to the virus, to a intracranial, the G207. So I don't know that we can't really. Presumably, those patients we had who seroconverted, it was from the virus that we stuck in, we injected into the tumor. So what that suggests is that patients who are naive, who have never had herpes virus, they will respond better than those patients who have already been exposed. So I don't think it would change what we would do. We would just know that those patients would do better than those patients who've already been exposed to herpes virus, HSV1. So.
Okay. And then in terms of the CSF sampling from those patients, did you find anything different, like that perhaps you would infer that it spread through the CSF system?
Well, so we only got CSF from that one patient who had leaked, because all the other patients we had tears, blood samples, and eye samples, or tear samples. So there was just the one patient who had a leak from their exit site of their catheter. So we did a lumbar puncture to make sure they didn't have meningitis or an infection. And they had benign appearing CSF, but we did find some herpes virus in it.
Okay.
So they did have it. So presumably, even if we put it in and we avoid the spinal fluid, the ventricles, it does get into the spinal fluid.
Okay. Right. Thank you very much. Then.
No problem.
Okay. Solomon, would you just say something to close? Please.
Yes. Okay.
Okay. You are mute.
Yes. Just a few words. I would like to say that I'm very happy to meet you all and to know that you are doing well. And I sincerely hope that everyone stay this way. I congratulate everyone involved in this meeting, and I'm very happy that we will remain going this way. Thank you so much, and I hope that in the near future we'll have another meeting like this. Thank you, and thank you, Jim, for your nice presentations.
It was an honor. Thank you very much, Dr. Salmo.
Okay, Ricardo.
This is our first meeting this year, so it was a great pleasure to have you here, James. I hope see you in Bogota.
Yes, I look forward to it. Thank you.
Yes.
Okay.
And see you, all the members of our society, in the next meeting. Thank you so
much.
Take care.
Bye-bye.
Bye-bye.
Thank you. Appreciate it. Thank you, guys. Obrigado. Thank you.